Hello there, I am John Carmelo M. Magno, and today I will be demonstrating on how to do a tracheostomy. Before we begin, we must know why do we perform a tracheostomy. So this procedure is for airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, and lastly, for the treatment of obstructive apnea. Tracheostomy is indicated due to different causes. For congenital causes, we have subglottic or upper tracheal stenosis, laryngeal web, laryngeal and valvular cyst, and hemangioma of the larynx. For infective causes, we have acute epiglottitis, laryngotracheobronchitis, diphtheria, or Ludwig's angina. For malignant causes, we have advanced tumor of the larynx, tongue, and pharynx, or the upper trachea presenting with stridor. For traumatic causes, we have gunshot and knife wounds to the neck, inhalation of steam or smoke, and swallowing of corrosive fluid. For vocal paralysis, it may be due to post-op complications of thyroidectomy, cardiac or esophageal surgery. And for foreign body causes, it may be due to swallow or inhaled objects lodged in the upper airway causing stridor. Before we begin, position the patient properly by letting the patient lie supine and extend the neck by placing a pillow under the shoulders. Then, sterilize the skin of the anterior neck and chest and drape the neck. First, we must identify the important landmarks. Let's start with running your fingers up the midline starting inferiorly at the suprasternal notch. Then the first prominence encountered is the thyroid isthmus. Then identify the Adam's apple. Then moving inferiorly, the finger slips into the depression of the cricothyroid membrane. Then the cricothyroid prominence. The incision should be at the level below the first tracheal ring or approximately 2 centimeters above the suprasternal notch. For demonstration purposes, we will use the line shown. The incision should be at the level below the first tracheal ring. So after planning the incision, make a horizontal skin incision 1 finger breadth below the cricoid prominence. Then, make an incision in the subcutaneous tissue, followed by the platysma and the fascia. Be careful to avoid transecting the anterior jugular veins located superficially to the strap muscles. Divide the intermuscular plane by spreading the pair of scissors. Then, separate the sternothyroid muscles and retract the muscles laterally. Next is to retract the thyroid isthmus superiorly with the Langed back retractors to expose the trachea. So this is the trachea. Next is expose the infrathyroid trachea. Ensure that the surgical field is completely dry before proceeding. In awake patients, inject lidocaine into tracheal lumen prior to incising to reduce coughing. Next is create an inferiorly based flap raised from the anterior wall of the third and fourth tracheal rings. Then, a silk traction suture is passed through the flap and is loosely secured to the skin. Assess the size of the trachea and insert the largest cuff tracheostomy tube. The obturator is subsequently removed and then insert the introducer into the tracheal tube. Then inflate the cuff attached to the anesthetic tubing. Hand ventilate while correct placement of the tube within the trachea is confirmed by checking the expired PCO2 and checking for the chest movement or listening for breath sounds. Thread tapes should be attached through the holes in the flanges of the tracheostomy tube and pass them around the neck. Tie them with the neck flexed. Then the ties should be tight enough to admit no more than a single finger under the rope. Then, suture the tracheostomy tube to the skin for the first few days until maturation of the tracheocutaneous tract. There are no absolute contraindications to tracheostomy. However, there is a relative contraindication for this procedure, such as laryngeal carcinoma. Complications in tracheostomy can be divided into three. We have the immediate, the early, and the late complications. So for the immediate complications, some of the examples are apnea, false root, bleeding, pneumothorax or pneumomediastinum, damage to the vocal cords, injury to the adjacent structures like the recurrent laryngeal nerve, post-obstructive pulmonary edema, hypotension, and arrhythmia. For early complications, we have early bleeding, plugging with mucus, tracheitis, cellulitis, tube displacement, subcutaneous emphysema, and atelectasis. And lastly, for late complications, we have tracheoinnominate fistula, tracheo and laryngomalacia, stenosis, tracheoesophageal fistula, tracheocutaneous fistula, granulation, scarring, and failure to decannulate.